My dear friends, in this case I encountered many setbacks and probably my interventions in this case were a little controversial. However, everything turned out fine in the end, and let's see how this case actually progressed. 95-year-old lady presented with bilateral mature cataracts and PL vision in both eyes. She had to be literally carried to the outpatient department. I decided to operate her right eye first. She had a non-dilating pupil of just about 2.5 millimeters, a very marked peripheral arcus senilis, and while injecting viscoelastic through the side port, I encountered a small epithelial detachment as well. I carefully performed a clear corneal incision. The entry into the anterior chamber was a little precipitous because of a slightly blunt keratome. The epithelial detachment I did not manage at this point, thinking that I would remove the epithelium if it grows bigger during the course of the surgery. So this is what the plan is: to put in viscoelastic, pupil dilating devices and continue. But while putting viscoelastic, I encountered my first setback. A 1/3 or a 30% Decemet membrane detachment occurred immediately, even before the case was started. This simply threw my composure a bit, and I did not know whether I should continue with this case or just put in an air bubble, settle the Decemet membrane detachment, postpone the case, and then take it after a couple of weeks, probably with a small incision cataract surgery. But considering the age of the patient, the fact that she's not ambulant at all and she's coming from a very far off village, and also because of the fact that the Decemet's membrane detachment completely settled with the injection of the air bubble, all things considered, I decided to move on, which was probably not such a great decision, but just let's see how the case progressed. So I first inject viscoelastic into the anterior chamber. By now the Decemet membrane detachment had completely settled. So I then committed myself to continuing with this case, and the first step is to use pupil dilating devices. Normally in a pupil which is of this size, I would do a pupillary stretch to eliminate sphincter sclerosis of the pupil before injecting the ring. But in this case, I did not suspect that the patient could have a sphincter sclerosis. I thought this was just senile meiosis, and therefore I went about trying to inject the Gupta ring, which I use. And only when I am trying to engage the loops of the pupil dilating device, I find that this pupil is very small and it is refusing to stretch. So with a little bit of struggle, I am able to engage 3 of the loops, and I think that I can engage the 4th loop as well. But while trying to retrieve the loop from the periphery, I think I created a small iridodialysis. In addition, just flexing this loop caused the other loop to bounce out of the pupillary edge as well. Now this is when I started suspecting that there could be a sphincter sclerosis. A little amount of blood is also seen from the area of small iridodialysis. So I decided to do a pupillary stretch. I started by using a Y hook and a Coughlin's hook to create the pupillary stretch. However, the Coughlin's hook did not give me sufficient amount of purchase and traction. It kept slipping. And so very soon afterwards, I replaced the Coughlin's hook with another Y hook, which helps to engage the pupillary edge better. I created a pupillary stretch, and in the course of which there was a lot of pigment dispersion that happened as well. So once I achieved a decent amount of pupillary stretch, I once again attempted to implant the pupil dilating device, and this time I was a lot more successful. The thick arcus annulus was definitely impeding my view for retrieving the loop, but the engagement of the loop onto the pupillary edge was made much easier after the pupillary stretch. So the beginning of the case, even before I started phaco, a considerable amount of time had elapsed. It's already 7 to 8 minutes had passed and I just got on the loop. And now attempting the capsulorhexis. The anterior capsule does not seem to be stained sufficiently. However, thankfully, because of the pigment dispersion and the fact that there is an intumescent cataract as well, I am able to see the tearing edge of the capsule sufficiently well to be able to perform the capsulorhexis. In the course of performing the capsulorhexis, I also find that the patient has slight amount of anterior capsular fibrosis. The capsule is a little thick to tear. Therefore, I switched over to a utrata forceps or an inamura forceps to enable me to have more control in tearing this capsule. So I have successfully completed a 5.5 millimeter capsulorhexis, or even slightly larger. I put viscoat to protect the endothelium. There is no evidence of the Decemet membrane detachment. The Decemet membrane seems to be behaving itself at this point. The patient has a very hard cataract, a grade 4 nuclear sclerotic cataract. And just before I start, there is a Decemet membrane detachment occurs again at this point. So I do not proceed further, I stop. And I come out of the eye, I inject some viscoelastic through the side port, and I don't know why, but this Decemet membrane is so mobile that just injecting the viscoelastic completely settled it into place. So I go ahead and I try to create the direct chop. I do not go to the sufficient depth in order to create the satisfactory chop. But experience kicks in, and sooner or later I am able to create the crack. The reason why the nucleus is rotating is because I am not holding the nucleus to the correct depth. You can see that the Decemet membrane detachment has not made an appearance. This is because I am using vacuum only after apposing the tip to the nuclear fragment. Only then I kick in the vacuum. So the message is, if there is a doubt in the back of your head, it will impair your performance. This is what you see. Under normal circumstances, I can take down this cataract quite easily, but so many setbacks playing on the back of your head can sometimes impair your performance. And I'm always watching out for the appearance or the reappearance of the Decemet membrane detachment to see that abnormal membrane fluttering around in the anterior chamber. And thankfully that is not happening, and I am able to impale the nucleus and then continue with phacoemulsification. I have created the 4 fragments by this point. Because the capsulorhexis is pretty large, I am able to mobilize the nuclear fragment, and I am in the burst mode and I am trying to eat up the piece when the Decemet membrane detachment once again occurs. This is probably because of using the high vacuum And this is a Venturi machine also, where the vacuum does not happen on occlusion, but it is on demand. So once again, go beyond the area of detachment, inject viscoelastic, a heavy OVD, which is viscode, and I find that this is enough to resettle the Decemet membrane detachment. I put in air at this point, and I think that I will take restraining sutures through the cornea in order to keep this Decemet membrane in place. So I go through the air bubble knowing that the Decemets would be attached at that point, pass it through the cornea, come out of the periphery. I angle the suture in such a way that it does not impede or pass through the clear corneal incision site. Of course, the right way to do it would be to pass it from the scleral end. I passed this to the corneal end, but I was able to tag on the Decemet membrane. 2 sutures were taken. Of course, the eye is not properly centered at this point in time, but you will see the 2 sutures soon. So 2 10-0 sutures taken through the cornea to anchor the Decemet membrane in place. And this is taken at an angle away from the clear corneal incision. Well, I am hoping that this would be enough to keep the Decemet membrane in place and make it behave while I perform the rest of the phaco emulsification, and let's see what happens. So I go ahead with the phaco emulsification using the direct phaco chop maneuver. I try to stay as far in the periphery as possible, going against the principle that you have to bring the pieces to the safe zone for emulsification. I try to emulsify it somewhere in the inferior periphery itself, so as not to cause the Decemet membrane to redetach. So slowly I am working at the pieces, I am emulsifying the pieces. Maybe I am emulsifying these pieces a little close to the endothelium than necessary. I am, however, hoping that the viscode would protect the endothelium. My primary concern is to finish the nucleus disassembly without causing the Decemet membrane detachment from recurring. So to protect the endothelium, I push in further viscode to not only reform the chamber but also to protect the endothelium. I take this interlude to rotate the nuclear pieces to a comfortable inferior position, and then I continue with phaco emulsification. Of course, I should have gone in without the flow, which would have been better if there is a Decemet membrane detachment. What I noticed is these 2 restraining sutures that I had applied is doing a pretty good job of keeping the Decemet membrane attached. So I am able to relax a little and continue with phaco emulsification and concentrate on the process of nucleus disassembly, and I am able to slowly eat away the nuclear fragments. A little bit of iris chaffing occurs, but this iris is not going to keep coming into the phaco probe because it is stretched with the pupil dilating device. It doesn't bother me so much at this point. So with very great caution, applying small and short bursts of ultrasonic energy, I am able to emulsify these fragments slowly. Some more viscoelastic is injected. You can see that this is a very hard cataract, a grade 4 nucleosclerotic cataract. So they say that when it rains, it pours, and in this particular case, there are so many complications stacked up against my favor. Of course, one of them was created by me. So then I reach a point where there is just a single piece of nucleus fragment to remove. The Decemet membrane detachment makes its appearance once again, and I can see the flapping Decemet membrane. So at this point, I have just a small piece to emulsify. And I changed the phaco mode from the burst mode to the micropulse mode. And I decided I'll just finish off this phaco emulsification. Of course, I have to be very careful that I do not aspirate the fluttering Decemet's flap. So I try to keep the phaco probe as far away from the Decemet's membrane flap. At this point, the irrigation flow from the phaco probe miraculously causes the flap to unfurl and resettle itself. Now this was indeed a stroke of luck. And as I removed the final piece of the nucleus fragment, the Decemet membrane detachment had completely unfurled and settled. So the last piece goes and the flap is reattached. There's hardly any cortex left, so I decide to implant the intraocular lens. This is a hydrophobic acrylic thickness single piece lens. So the trailing haptic is delivered outside the incision, and using a visco cannula, I'm able to push the lens inside the capsular bag. So the remaining viscoelastic is washed out using a bimanual IA. I make 2 stab incisions on the cornea for the bimanual IA, as I think that it would be safer than a coaxial IA passing through the main incision. So a little bit of viscoelastic is washed out. And after which the pupil dilating device, the Gupta ring, is gently disengaged from the iris and removed. So once the ring is out, the remainder of the viscoelastic is washed off. Gently with the bimanual IA cannula itself. That shaft portion of the iris shows a tendency to come into the aspirating port, as well as shows a tendency to prolapse. So I reposit it. I put in a big air bubble to fill the anterior chamber and to dampen out the Decemet membrane. I use a cotton bud to give pressure over the incision site so that the air bubble will not escape. So I stayed like this for a period of 5 minutes, which is edited in this video, to give sufficient time for the Decemet's membrane to attach. At the end of the procedure, I removed the 2 restraining sutures, as their utility is now of doubtful value, and that ends the case. Postoperatively, the patient had severe striate keratopathy on day 1, but second week it was a considerable amount of the cornea had cleared. The best corrected visual acuity was 6/18. The cornea thickness looked normal. There was striate keratopathy on top. There were no residual Decemet's membrane detachment, and I'm counting my blessings. Thank you for your attention.